I'll be talking about medico-legal litigations in gestational diabetes, mellitus and diabetes in pregnancy, golden tips how to avoid litigations. So GDM prevalence is to the tune of 15 to 20%, but it is going to increase, and increase by leaps and bounds, reaching about 30% by 2030. And we know that nothing is more expensive than a missed opportunity. So pregnancy is one time that the patient is compulsorily with a gynecologist, with a doctor. It's a duty to screen. That is and has to be universal screening in a country like India. So I'll just show you some case scenarios. A primary gravida, 31-year-old, reported at 6 weeks of gestation with a BMI of 23, BP 124/78, and no significant past medical history, but a strong family history, with a strong family history of parents having type 2 diabetes. Screening with DIPSI after 75 grams of glucose was done, and the blood sugar were 106 fasting because she came fasting, and PP was 148. So she was diagnosed as GDM and started on MNT and exercise. 2 weeks later, her blood sugar levels was 136 after meal on self-monitoring of blood glucose. She was put on insulin, but pregnancy terminated in spontaneous miscarriage 6 weeks later. So this after the pregnancy, postpartum, 6 weeks postpartum, 75 grams OGTT was done, and it was reported to be normal. And patient was advised to follow diet and exercise and to report 6 months for checking blood sugar levels and HbA1c. We should all know that poorly uncontrolled blood sugar levels in first trimester or before pregnancy can cause major birth defects, miscarriages, and stillbirths. So now she reported again 6 months later with a 6 weeks pregnancy. That is the second pregnancy. And her BP was 124/76. Screening again was done with DIPSI, and sugar fasting came 108 and PP came 148. She was diagnosed. Now we learned the lesson from the previous pregnancy. She was started immediately on insulin aspart on 3 doses along with MNT and exercise. Put on SMBG, that is self-monitoring of blood glucose, 7-point charting. That is fasting and pre and post meal before breakfast, lunch and dinner, and at 3 a.m. that is a 7-point charting. It can be done every third day or more frequently as required by the blood sugar levels. Insulin dose requirement, we know, increases with the advancing pregnancy, increase up to 50 units by the end of pregnancy. Pregnancy progressed and LSCS was done at 38 weeks due to cephalopelvic disproportion. Postprandial blood sugar levels were normal, so insulin was stopped. 6 weeks later, 75 grams, again OGTT was done and reported to be normal. So this was a very unusual case who was presenting in very early pregnancy, and she was not a pre-pregnancy diabetic as such. So she was advised that to follow up with diet and exercise and to report after 6 months for checking blood sugar levels and HbA1c. Was counseled to do blood sugar levels every 6 monthly and OGTT every 3 years because she seems to be at a very, very high risk. Another case, a 28-year-old reported at 32 weeks of gestation in a second pregnancy with ultrasound diagnosis of large for gestational HPV. Her BMI was 30, BP was 124/78. Again, screening with DIPSI. Till now, no screening was done. So it was done with 75 grams glucose, and fasting blood sugar was 110 and PP was 180. Diagnosed as GDM, started again because it is in third trimester. We don't have time to give 2 weeks for MNT and exercise. So immediately she was put on, along with MNT and exercise, she was put on insulin. Put on SMBG 7-point charting every third day or more frequently as required. Insulin dose increased, pregnancy progressed, and she reported decreased fetal movements. An LSCS done at 38 weeks due to non-reactive state of NST. Outcome was again a baby girl of 4.2 kgs. So in spite, although we were managing her late, but still we had a problem. And another case, 30-year-old reported at 32 weeks of gestation, first pregnancy at 10 weeks. I'm going back. Sorry. So this is a 34-year-old reported at 38 weeks of gestation in fourth pregnancy with IUD. Her BP was 132. At the admission, the sister said, I can hear the fetal heart. But by the time I went and checked, there was no fetal heart. And she was a fourth gravida. And it was very sorry state. The baby born was 4.5 kg. BP was BMI 32 and BP 140/94, and random blood sugar done was 308. And the baby being such a high large for gestational age, we had to go in for a CS even with an IUD. The patient was not ready to wait. Another case, at 26 weeks, she came with multiple congenital anomalies on ultrasound. And she, on ultrasound, later on she presented with, she wanted a termination at 26 weeks, but it was because there were multiple congenital anomalies and it was reported that they were lethal and the pregnancy would not continue, and she went into spontaneous IUD with BP did show a little bit high. Blood sugar was again 108 and 180 on DIPSI, went into spontaneous IUD after a week and delivered. So these are real case scenarios we see day in and day out. So we have to have crystal clear guidelines for diagnosis, treatment and monitoring given to us by Government of India. So we have to see that we should never be missing universal screening by DIPSI. You can do by any other method, IADPG method also. But for us, DIPSI is most useful because many times the patient does not come fasting and she does not want to come again and again. So DIPSI is very easy. You just administer 75 grams of glucose with half a glass of water, has to be consumed in 5 to 6 minutes. And if there is vomiting within half an hour, the glucose load has to be given again. Or if it is after half an hour, we can continue with the test. So improper MNT advice, if given, not switching to medical treatment in line, in time, metformin or insulin, mismanaged insulin therapy. If you are incapable of doing that, seek an help of your colleague. If the patient needs that sort of help, let whatever be the cost, but you have to advise on your paper that you refer the patient to an endocrinologist. Although it's very easy, if you learn managing yourself, you would be the best judge. So hypertensive disorders of pregnancy also come with GDM plus diabetes mellitus is a deadly combination. So we have to see that poor communication about maternal and fetal complications and mode of delivery and PPH can be the reason when the patient can give you trouble. Missed complications and fetal surveillance for large gestational macrosomia that is greater than 3.5 and fetal anomalies can result in litigation, as Dr. Divya has already said. Misjudgment to exclude outlet CPD, resulting in fetal injuries due to instrumental delivery and shoulder dystocia. I think I skipped the case of the shoulder dystocia. That patient came with polyhydramnios and she went into spontaneous leaking and labor at 36 and a half weeks of pregnancy. And she was progressing well. And the baby was 3.6 kgs, but landed into shoulder dystocia. Was managed conservatively, but still the complication did arise. So failure to screen and monitor, not following standard protocols for maternal glucose control and surveillance, assessment of baby weight and timely delivery decisions when there are clear-cut guidelines, improper judgment of timing of mode and place of delivery, inadequate neonatal care for common complications like respiratory distress or hypoglycemia. Because these neonates who are born to hyperglycemic mothers, they are used to high glucose load, and post-delivery, they go into hypoglycemia very fast. Delayed or improper referral, endocrinologist and tertiary care hospital, not there. So documentation gaps, communication plus documentation is the baseline. So incomplete documentation of patient counseling, monitoring and interventions can lead you to litigations. So there is a universal testing for GDM according to DIPSI. I told you how it is to be done. And it is positive if 2 blood sugar levels post-glucose load are more than 140. Then if it is more than 140, then you have to manage as GDM. If it is negative, you repeat the testing. So this was at the booking. You repeat the testing at 24 to 28 weeks. There is an additional caveat now that if you want to prevent the baby from becoming diabetic, you have to diagnose this glucose intolerance on a self-monitored blood glucose levels, not a OGTT, only self-monitored blood glucose levels to be done at 8 to 9 weeks of pregnancy, because by 10 to 11 weeks, fetal pancreas form. So that is the time the fetal pancreas get sensitized to hyperglycemia. So before that, if you are doing an SMBG and if the blood sugar levels are more than postprandial, blood sugar levels are more than 110, the patient can be put on 250 milligrams of metformin as per Dr. Sesaya to prevent the baby from becoming diabetic. You are trying to modify the epigenetics for the baby. So if now we come back to just our own routine case, this we have to do SMBG, and if that is we have to do DIPSI. If it is negative, we repeat the testing at 24 to 28 weeks, because we know hyperinsulinemia keeps on, that is insulin resistance keeps on increasing throughout the pregnancy. So it has to be done at 24 to 28 weeks. You can again repeat it at 32 to 36 weeks. Positive, manage as GDM. If negative, again, you can always counsel the patient to stay on dietary compliance and exercise, which would not harm her. But these blood sugar levels are on OGTT. If the patient is monitoring on self-monitored blood glucose level, the levels have to be less than 120 per milligram per deciliter in a 2-hour postprandial test, and sugars in high-risk patient to be done every 2 weeks. Simple adage, every 2 weeks in second trimester and every week in third trimester. The patient can do it herself very well. Glucometers are pretty cheap and available in the market. So management of pregnant women, we put the pregnant woman, if the levels are not very high, sugar levels. So we put her on medical nutritional therapy. Medical nutritional therapy plus exercise plus good sleep hygiene have compounding benefits to the patients. And we again repeat to our postprandial blood sugars after 2 weeks. And when we are doing a self-monitoring, the levels, levels to be considered is not 140, it is 120. If it is less than 120, we continue with the same. If it is more than 120, we start with either metformin or insulin. The advantage of starting the patient on metformin is it also decreases the risk for hypertensive disorder of pregnancy, but not when metformin is being given in a preventing form that like we give in PCOS patients. Then this role is not there, but only when we are managing GDM with metformin, the patient, the risk for HDP also lowers. Another thing is that metformin lowers vitamin B12 levels also. And a high ratio of folic acid, which we are routinely giving. The falling levels of B12 and folic acid supplemented from outside becomes another risk factor that the patient's GDM would worsen. So you have to be very careful and monitor again. So this once this patient is on has been labeled as diabetic, a GDM, she has to be managed accordingly. So diabetes, hypertension, GDM, and IUGR are a lethal combination for the baby, and we have to be very careful. We can have complications like stillbirths and fetal and congenital malformations, spontaneous abortions, stillbirths, shoulder dystocia, neonatal hypoglycemia, neonatal hyperbilirubinemia, polycythemia, IUDs, congenital malformations, birth injuries, infant respiratory distress syndrome, and long-term clinical effects of GDM on the baby and the mother both. Could be diabetes mellitus, non-communicable diseases, and cardiovascular diseases. Now they are being called as metabolic disorders because it includes obesity, diabetes mellitus also. So treatment is 70% can be controlled on MNT, 25% need pharmacotherapy, only 5% would need insulin therapy. So monitoring. We have to continue the monitoring even if the sugar levels are coming normal. You just have to keep on counseling the patient that monitoring would do her no harm. Rather, we can pick up the condition pretty early before it affects her baby and herself. And the management has become pretty simple. Insulin therapy has been made very easy. If our postprandial blood sugars are more than 120, we have to start with insulin, which is a premix of 30 and 70. That is 30 is short acting and 70 is intermediate acting. It's a subcutaneous injection 30 minutes before breakfast once a day, and dose is calculated according to the postprandial blood sugar levels, which are here. So if the levels are 120 to 60, we start with 4 units. 160 to 200, we start with 6 units. And if 200, we start with 8 units. And again, keep on monitoring on the 7-point chart, done every third day. And if it is less than 20, we continue with her MNT and exercise, and again monitor her with blood sugar levels. and switch over to insulin as and when required. So if now on insulin therapy, there could be three scenarios. If both are well controlled, fasting blood sugar less than 95 and postprandial less than 120, we continue the same dose. If the fasting is normal but only postprandial is raised, we increase the dose of insulin which was being given pre-breakfast by 2 units. Okay, and if both are increased, if fasting also and PP also, now we divide the doses. We give insulin 2 doses, same dose is being given. Suppose she was on 6 units, we give 2 units pre-breakfast and 4 units pre-dinner. So repeat fasting every third day, and you can all keep on adjusting the insulin dose as you require. So there is, we have seen that many patients who are being managed very well, still they land up into complications. Why? Because as India is a diabetic population, we are doing only point-to-point test. So maybe this continuous glucose monitoring, which says that all the time there should be 80% when the sugars have to be in range. And this can be done only by continuous glucose monitoring. When we are doing only point-to-point test, then we might miss the cases where there are times when there are when there are spikes. The patient has taken mid-meal something and there is a spike in sugar. And again, she is doing only the meal one, lunch and dinner. So we would not catch that postprandial hyperglycemia. And target above range, only 15% is allowed, and target below range, only 5%, because we don't want hypoglycemia. It will affect the baby's growth also. So this was a study which was done in 14 countries, including India. And this was the outcome, that the time in range, the blood sugar levels should be greater than 80% to get the best outcome. So labor and delivery, no home delivery, that is very clear. Delivery at their respective health centers can be done if good blood glucose control is there, do our SMBG blood sugars to be less than 120. We have to deliver at higher center with a NICU facility if blood sugars are uncontrolled, or patient is on insulin, especially when the requirement is greater than 20 units per day. But simple adage is, if blood sugar uncontrolled, send her to a higher center. Don't deal at a lower center. So timing of delivery has to be individualized. Delivery less than 39 weeks is not recommended, as respiratory maturity in GDM patients for those babies is delayed. Delivered early with poor glycemic control, hypertensive disorders associated, or there is a history of previous stillbirth. Vaginal delivery is preferred.
Vandana, we will take comments now. We'll take comments now.
Yes, but ma'am, three more slides. So vaginal delivery and only LSCS for obstetric indication. Consider primary cesarean at 39 when macrosomia. So DDM litigation, friends, 50% of medico-legal cases in OBS involve no screening or poor monitoring. Increased cases is again gynecologists in urban India due to rising awareness among patients and easier access to legal system. Studies show 80% litigation arise from preventable complications like macrosomia and stillbirth. In US, GDM-related lawsuits frequently cite a lack of adherence to ADA guidelines. So golden tips: follow standard guidelines, do comprehensive counseling, and meticulous documentation. So concluding tips: in the era of rising litigation, best defense tips are adherence to guidelines, proactive communication, counseling, diligent documentation. Prevention is always better than litigation. Thank you.